Hi guys, welcome to this short vlog on steroids. So steroids are a controversial thing in the ICU. You know what kind of steroids we should give, what dose, when to give. So just to clear that confusion, I made this short vlog, and there are three questions I will answer. Why there are different types of steroids? What are the differences between them? When we should give steroids in the ICU? And what are the dosing? So first of all, mm, brief trivia about steroids. Steroids were first discovered in the human body in around 1950, and cortisol is the naturally occurring form in the body. And its first use was in a rheumatoid arthritis patient. And the effect was so dramatic in terms of relieving the pain that it got the person the Nobel Prize. And subsequently, its use is very dominant in rheumatological conditions and rheumatological emergencies. Another trivia is about dexamethasone. Now, dexamethasone is a preferred steroid in brain conditions. Why is it so? So, I started around 30 years back when a neurosurgeon was trying to discover some kind of treatment for brain tumors. And dexamethasone, is used in oncological malignancies. So he gave dexamethasone, hoping that it might work for brain tumors. What he saw then, after a couple of days, was that the patient's hemiparesis had remarkably resolved. And then the CT, the edema was very much decreased. So that's how dexamethasone has come into use for brain tumors associated edema. And subsequent work was done, and one thing led to the other. Now, cortisol is the naturally occurring form, and the other forms are all synthetic. And what are they that we use in the ICU? That is the intravenous formulations. We have hydrocortisone, we have methylprednisolone, and we have dexamethasone. Their oral formulations are also available, and we have prednisolone also as oral formulation, but generally we use IV. So I'll restrict my talk to these formulations. What are the differences now? What are the differences between the different types of steroids? When do you give one? When do you give the other? So the first difference is in the mineralocorticoid activity. What is mineralocorticoid activity? It is the salt and water retaining property. Salt and water retaining property of the steroids. So actually, steroids are corticosteroids. And what we talk commonly call steroids are glucocorticoids. The other kind of corticosteroids are mineralocorticoids, which is aldosterone and aldosterone-like steroids, and they have predominantly salt and water retention. But glucocorticoids also have some salt and water retaining properties. But this differs amongst hydrocortisone, methylprednisolone, and dexamethasone. Highest is for hydrocortisone, intermediate for methylprednisolone, and least for dexamethasone. In fact, dexamethasone does not have any salt and water retaining properties. So this becomes important because if you have a patient with CHF, or if you have a patient with edema, or you don't want brain edema also. If the patient has brain edema, you don't want salt and water retention, right? Therefore, if you are going to give it to 1 or 2 days, it's all right. It doesn't make any difference. But prolonged usage or high dose usage will lead to sodium and water retention. So this is one major difference. You have to see the clinical condition and use accordingly. The second difference is regarding their potency. So potency means that steroids having different dosing. For example, dexamethasone has the maximum potency, methylprednisolone has intermediate potency, and hydrocortisone has the least potency. 300 milligram of hydrocortisone is equal to 660 milligram of methylprednisolone is equal to 10 milligram of dexamethasone. They have the same clinical effect at these dosing. But at higher dosing, at extremely high dosing, dexamethasone has maximum potency, has maximum clinical effect. So this is another difference. The third difference is related to their protein binding. So there are different protein binding properties. And when these steroids bind to protein, some is bound to protein, some is free. And the free form is the one responsible for clinical features. And in critical illness, albumin decreases. So obviously the free fraction increases and the clinical effect increases. But this is not really relevant in terms of dosing. Dosing doesn't change, but this is another difference. Now, the fourth difference is regarding the duration of action. Hydrocortisone's effect lasts less than a day, methylprednisolone for a day, and dexamethasone for up to 3-4 days. So duration of action is again different. The fifth difference, there are five real differences. So the fifth difference is in terms of their clinical mechanism of action. How do steroids act? So the main mechanism is what is called genomic effect. These steroids bind to the receptors, and the receptor steroid complex goes into the cytoplasm, into the nucleus, and binds to the mRNA and affects the transcription of mRNA. So that is the main effect and is called genomic effect, mechanism of action. This is the same for all, right? And there is something known as extra genomic effect also. That is when it does not act through mRNA. And this is not well understood. What are the extra genomic effects? And therein may lie some of the differences which you do not understand in terms of their usage. For example, for rheumatology conditions, we prefer methylprednisolone. But for brain conditions, we still prefer dexamethasone. Why that is so is not really understood very well, but that is the way it is. And this probably we may know in the coming years as more is understood about their extra genomic mechanism of action. Now, coming to their usage, that was the differences. So if you understand these differences, the main being their potency and the mineralocorticoid difference, and of course, the duration of action, that is the key feature to understand. Now, their usage, when to use them? There's so much confusion, right? Are we really requiring steroids? Because steroids are harmful, they have significant side effects. So first we talk about septic shock. Should we give them? Yes. We give 200 milligram per day when the patient is requiring moderate doses of vasopressors. So that is around NORAD 15 microgram per minute. You start hydrocortisone 200 milligram per day. And hydrocortisone is good here because it has a short duration of action. And even if it retains some salt and water, you require some salt and water retention in conditions of shock. Then this actually usage in steroids in septic shock has become less strong as far as evidence is concerned. Initially, it got a stronger yes, now it is a weaker yes, but still it is recommended. The second situation in sepsis is a condition called CIRCI, C-I-R-C-I, critical illness related corticosteroid insufficiency. So what is this? This is a poorly understood condition, right? It is not well described. There is no diagnostic test. Measuring serum cortisol level does not help in the ICU, nor does ACTH stimulation test. Don't measure cortisol levels. Now, what happens in CIRCI? Or when is it suspected? It is suspected when the patient is not coming off vasopressors. The disease has resolved, the shock has resolved, but the patient is still requiring 5 microgram of noradrenaline. So here you can try small doses of methylprednisolone. You give 40 milligram in the morning, 20 milligram in the evening, and the patient's blood pressure will respond. So this is CIRCI, and it is supposed to occur later in the course of illness, not early, around 3 to 4 weeks into illness, right? So that was about septic shock. The other condition is adrenal insufficiency, Addisonian crisis. Patient has a primary adrenal disease and he comes to you, you do not know whether he has adrenal disease or not. Okay, adrenal crisis is a type of shock and the patient's blood pressure will not respond to vasopressors, right? And you give steroids and there'll be a dramatic improvement. So this here requires 200 milligram infusion after 100 milligram bolus of hydrocortisone. And hydrocortisone is again preferred here because it is very similar to cortisol, right? It is a synthetic form, but it is just like cortisol and it is a naturally occurring cortisol, which is deficient. So you replace it with hydrocortisone, which is just similar to cortisol. And the other thing is, you want to measure the cortisol levels to diagnose adrenal insufficiency. So either you send the cortisol level before giving the steroid, because you give the steroid, the hydrocort, and then send the sample, it will interfere with the measurement of serum cortisol. If you cannot send the serum cortisol, then give dexamethasone first, because dexamethasone does not interfere with cortisol lab testing serum levels. So that is another point. Now, related to adrenal insufficiency, some patients have Addison's disease and they are on replacement doses of cortisol. So here, when they come to the ICU, they're stressed out. They may not be having primary adrenal insufficiency in terms of shock, but they are on maintenance doses. And when they are stressed, the body is supposed to release more cortisol. The body requires more cortisol. So you have to increase the dosing of exogenous steroids here, right? And generally 2 to 3 times of steroids are given as compared of 2 to 3 times of their basic dosing. Now, moving on now, where are the other places where you use? You use it in brain conditions, you use it in lung conditions, you use it in the heart, you use it in the liver, you use it in rheumatology conditions. So briefly, we'll just recap this. Now, starting from the top, brain. In the brain tumor or tumor-related edema. Okay, the dose is 4 to 10 milligram Q6H. How it acts, nobody knows. And probably because they have oncolytic properties, steroids, dexamethasone especially, it may help in that way. Then it helps in acute bacterial meningitis. Acute bacterial meningitis dose in an average adult of 75 kgs would be 10 milligrams 6 hourly. Again, you give dexamethasone. And you have to give it half an hour before giving the antibiotic. Because by giving it before, you suppress the inflammation, which is caused when you give the antibiotics, and these antibiotics are leading to lysis of the bacteria and release of cytokines. Do not give it after the antibiotic dose. That is another thing. And you give it for 4 days. It's primarily for pneumococcal meningitis. So if you get another diagnosis, etiological diagnosis, or if the diagnosis is pneumococcal clearly on culture, then you do not give, that is if you diagnose pneumococcal or if the diagnosis is not clear, then only give it. If you get another culture positivity like meningococcal or H flu, then it does not help, don't give it. Now, it is also given in brain abscess. Again, you give dexamethasone to reduce the edema. It is also given in neurocystic sarcosis, where the dose is less than 8 milligram per day, because when you give the albendazole, then there is inflammation, and when there's release of all the cystic sarci, so it reduces the inflammation. This is all dexamethasone, but you can also use methylprednisolone, and especially in rheumatology or immunology conditions such as you have edema associated with viral encephalitis. You give methylprednisolone. You can give anything like 250 milligram per day IV, or in conditions such as autoimmune encephalitis, you give methylprednisolone. So methylprednisolone is also used. Similarly, you give in tubercular meningitis, where again dexamethasone is preferred. So that was about the brain. Now moving on to the lungs. In the lungs, you have asthma exacerbation, COPD exacerbation. So what is the dose here? There is no scientific dose here in terms of trials, but what is recommended is 60 milligram methylpred in asthma and COPD daily IV. Okay, maximum dose if the patient is not improving, you can try up to 125 milligram 8 hourly. That is max. But standard dose is 60 milligram per day methylpred, and duration in asthma is around 5 to 7 days. In COPD, 5 to 14 days. It's variable depending on the response. Now, recent studies have shown that severe pneumonia, it helps. And you give in severe pneumonia 200 milligram of hydrocortisone or equivalent. Anything, you can give equivalent doses of methylpred or dexamethasone, and duration is again variable around 7 days or a little more. Then ARDS. So in ARDS, including COVID, you have given in COVID. So you're supposed to give in even non-COVID ARDS now. There was a lot of confusion earlier, but in ARDS, 6 to 20 milligram per day. Duration is again variable, 10 days, and the trials were done with dexamethasone, but you can give methylprednisolone or hydrocortisone. So that is about ARDS, severe pneumonia, COPD exacerbation, and asthma exacerbation. Severe pneumonia is loosely defined. If the patient is really sick with pneumonia, it becomes severe pneumonia. Where else is it used in the lungs? In the lungs, it is also used in laryngeal edema. So you extubate the patient goes into stridor, he has laryngeal edema. So here you give nebulized form. And nebulized form is dexamethasone, 4 milligram with 1 ampule epinephrine. And you can repeat it after 1 or 2 hours. So that is another use of steroids in pulmonary conditions. Now, moving away from the lungs and the brain, where you use it quite frequently. In the liver you use for alcoholic hepatitis, which is again very frequent in the ICU because alcoholic patients are very frequent in the ICU. So in alcoholic patients, you're supposed to calculate the Madrid discriminating fraction, which should be more than 32. And if there is no contraindication, you give the steroids, whatever steroid you can give IV or oral in the dosing recommended is okay. Now moving on to the heart. In the heart, sometimes you get patients suspected viral myocarditis, right? So there's a fulminant acute heart failure, fever history, arrhythmias. There's no other young patient generally, and there's no clear diagnosis. You think the patient has viral myocarditis. So steroids are not recommended for viral myocarditis, but often most of the times you won't be able to establish the diagnosis of viral etiology. And the differential of this is giant cell myocarditis and sarcoid myocarditis and other types of myocarditis which respond very well to steroids. So here again, if there's acute myocarditis, give steroids. And pulse therapy is to be given 1 gram per day for 3 to 5 days. What is pulse therapy? I will tell in the end. In the heart, you are again used in constrictive pericarditis, right? Low doses of prednisolone, around 40 to 60 milligram per day, are given. Then moving away from that, you go on to other conditions such as anaphylactic shock. In anaphylactic shock, its role is not much. All right. Don't think steroid do wonders in anaphylactic shock. You can give 1 shot of 60 to 120 milligram methylprednisolone. So it has some effect, but there is no remarkable efficacy of steroids in anaphylactic shock. Apart from this, you also use it in rheumatology conditions. You are well aware, rheumatology is associated with steroids. Like I told you in the beginning, the first use was in rheumatology patients. So in rheumatology patients, such as lupus coming with all kinds of severe complications, or other rheumatology conditions, immunology conditions like Goodpasture syndrome, pulmonary hemorrhage, renal failure, these patients sometimes come with devastating illnesses. Pulse therapy is given. And what is pulse therapy? So pulse therapy is supraphysiological doses of steroids, and anything which is more than 250 milligram of methylprednisolone per day is pulse therapy. Why we give pulse therapy? Because you can give high doses at shorter duration, and this high dose is supposed to act immediately, and its effect lasts for a few weeks. And when you see the total dosing of pulse therapy, the side effects are much less as compared to when you give over a longer time. So that is the rationale behind pulse therapy. And you use methylprednisolone generally in pulse therapy. This is as per whatever evidence is there, but you can use DEXA also. So these were some of the points about use of corticosteroids in the ICU. And one last thing I would like to tell you is when you give the infusion, do not give it as a bolus infusion of pulse therapy. The pulse therapy steroid has to go over around half an hour in 500 ml dextrose. Otherwise, it can lead to cardiac arrest, arrhythmias, etc. So please be careful about that because often you'll be at the bedside and the infusion is running. And that is the latest thing about steroids. This is all up to date. Things can change in the coming time because steroids still remain controversial. But please remember, as far as the differences are concerned, potency and mineralocorticoid activity. And all steroids can be used interchangeably. But there is some preference, like I told you, for certain situations. So that is all. And if you like this and If you have any questions, please put them up in the comment section. See you till the next short video. Bye bye. Take care.